Rheumatoid arthritis, primarily an autoimmune disease. After the completion of this presentation, the viewer should be able to describe the cause, frequency, and implications of rheumatoid arthritis, also simply known as RA, outline the non-pharmacological methods used to treat RA, and finally be able to compare and contrast the most common medications used to treat RA, including mechanisms of action and potential side effects. Arthritis is Latin, meaning inflamed joint, and collectively it's a major cause of disability in the United States and other countries, for adults certainly, but also children. About 22% of American adults have a doctor-diagnosed arthritis of some type. I'm not talking about just RA here. And prevalence is 50% for people 65 years old and older. There are over 100 types of arthritis currently understood or at least categorized. RA is not the most common type. OA or osteoarthritis is, but RA is certainly one of the most destructive and painful. RA has been recognized for over 200 years. It was first described, medically at least, back in the year 1800 by a French doctor, I believe out of Paris. Although it was described, certainly it wasn't well understood, and even 200 years later, it's not all that well understood. RA is a chronic inflammatory disorder that typically affects joints of the hands and feet, such as fingers, toes, ankles, and wrists. Although widespread systemic inflammation, which can affect tissues and organs, is not uncommon. Basically, RA affects the synovium of joints and of synovial joints, which is the lining of these sorts of joints. And it causes severe swelling and pain, eventually leading to bone erosion and joint deformity. And usually the very highly deformed hands that can be seen in the elderly, that's caused by RA, much more so than OA. In fact, RA is quite different from OA. And OA is really a degenerative condition that slowly destroys cartilage, connective tissue, and bone. The big thing about RA is it's much more inflammatory, it tends to be more disfiguring, and tends to be more painful. At least 1.5 million American adults have RA, and these people are usually between the ages of 30 and 60, and of course it's much more common in women. The cause of RA is currently not well understood, at least by the mainstream medical community, and therefore it's classified as an autoimmune condition without a known cure. As mentioned, RA involves inflammatory response of the synovium, and secondary to synovial cell swelling, also called turgescence, excessive synovial fluid production within these synovial joints, and pannus development. And a pannus is a medical term for an abnormal layer of granulation tissue, or you could also call it fibrovascular tissue. And the inflammation thickens the synovium and eventually destroys cartilage and bone within joints. And these joints essentially fuse together, which is known as ankylosis. Now, OA can take this path too, but it destroys cartilage in a different way. It's not so much an inflammatory process. OA, of course, is more about wear and tear, grinding that cartilage down. And the cartilage loses its ability to absorb water and loses its cushioning ability. Anyway, with RA, tendons and ligaments weaken and stretch, and the joints typically become unstable and misaligned, and that contributes to the deformity within the hands and feet and even in the spine. RA affects other organs between 15 to 25% of the time, and typically it causes the most amount of inflammation in the lungs, in the pleura, with the eyes, in particular the sclera, the heart, the pericardium, the upper cervical spine, particularly what's called COC1 at the base of the skull, and RA also forms subcutaneous tissue known as nodes or RA nodules. RA involves chronically elevated immune response characterized by a number of factors. Mainly, abnormal interaction between lymphocytes or white blood cells, particularly B cells and T cells. Essentially, the B cells present antigens to the T cells, and this triggers production of rheumatoid factor. Actually, it should be rheumatoid factors, plural, because there's more than just one, and antibodies to citrullinated peptides, also known as ACPAs. Inflammation is driven either by B cell or T cell products stimulating the release of TNF, or tumor necrosis factor, and other cytokines, typically the various interleukins. Interestingly, the disease progression can be slowed down by blockage of either the TNF alpha or depletion of B cells. And typically pharmaceuticals are tailored towards this mechanism. Other immune cells that are relevant at the site of inflammation include plasma cells, which are actually derived from the B cells. Overall, the immune system is considered faulty or confused or overactive with RA. Well, in the standard medical model, an autoimmune condition occurs because certain cells, the B cells and the T cells that I just mentioned, of the immune system are thought to malfunction or be faulty in some way. And it's either usually due to genetic factors that affect the lymphocyte production directly, or genetic factors that impact connective tissue type or hormone balance, for example, which would be more indirect effects. Now in RA, it appears, and I do say it appears, that lymphocytes attack otherwise healthy synovium tissue. And of course, this tissue lines the insides of synovial joints, the typical ball and socket type of joints that make up our knuckles and hip joints and lots of spinal joints, these sorts of things. So RA is basically viewed as an autoimmune self versus self condition. But the issue is self-antigens can't be removed from the body. So chronic response and inflammation persists for long periods of time. Now, this is in the medical model, of course. Now, within the autoimmune label, RA is often classified as type 3 immune complex disease, particularly when the RF or rheumatoid factors are present. But it's sometimes also labeled as type 4 cell-mediated disease when there's no rheumatoid factors present. The most common symptoms with RA are severe joint inflammation, pain, redness, and warmth. You can see in the little diagram of the skeleton where it's most common. And it affects the hands, the feet, including the ankles and the wrists, the knees, of course, glenohumeral joints of the hips, sometimes the elbows, even the shoulders, and as I've mentioned, spinal joints, in particular the upper C-spine. With RA, there is joint stiffness, and it's worse in the morning, lasting several hours, which is a distinguishing factor from OA, which doesn't last that long in the morning and it improves pretty quickly with motion. RA does not. It typically lasts a lot longer than OA would. Other signs and symptoms include reduced range of motion, loss of joint function, muscle pain. Typically starts in smaller joints bilaterally or on both sides of the body, in the hands and feet, but then it spreads to the larger joints such as knees, shoulders, and hips. And then, of course, it may progress in 15 to 25% of the time to various organs. RA is also associated with fatigue, low-grade fevers, anemia because of issues with red blood cells, and also weight loss over time. Periods of increased symptoms, also called flares, alternate with periods of relative remission. And that's when the pain and swelling fade or even sometimes disappear altogether. And again, that's in contrast to OA, which is fairly constant in terms of the symptoms. With RA, you typically see firm lumps called rheumatoid nodes or nodules that are growing beneath the skin around the joints, particularly of the hands and feet. And of course, RA is not just for adults, it can begin in childhood. The second diagram on this slide to the far right, you can see the destruction of cartilage. And again, this is more due to the inflammation, the inflammatory products that are in the synovial fluid. This is not a wear and tear grinding issue like it would be within osteoarthritis. And over time, the destruction of the cartilage and the inflammatory products erodes and destroys the bone within these joints. As mentioned, aside from joint swelling and pain, RA can affect various tissues and organs. For example, inflammation of the glands of the eyes and mouth can cause dryness, and overall it's classified as Sjogren's syndrome. And this eye dryness can lead to abrasions, scleritis, and even blindness in a small percentage of cases. Pleuritis of the lungs can cause chest pain, shortness of breath, excessive coughing. Pericarditis of the heart can lead to chest pain, increased risks of heart attack. RA can reduce red blood cell production and function, as I noted earlier, leading to anemia. And of course, it affects white blood cells and reduces their production and effectiveness, which can increase risk of infections, create an enlarged spleen, and a little higher risk of lymphoma. RA nodules can put pressure on tendons and ligaments and nerves, and if this occurs in the wrist, it can trigger carpal tunnel syndrome. Chronic long-standing RA is associated with vasculitis or inflammation of blood vessels, and this impairs the blood flow to tissues, can lead to tissue death or necrosis, particularly in the hands and the feet. And in this way, it can appear similar to the symptoms of severe chronic diabetes, but of course the cause is different. In diabetes, it's due to too much glucose in the bloodstream, affecting nerves and blood vessels. And with the case of RA, well, it's quote-unquote autoimmune and inflammatory products. RA can also inflame the spinal joints and make them unstable, which is particularly, we can say, dangerous, I suppose, when it happens in the upper neck, so-called COC1, where the top cervical vertebrae attaches to the base of the skull. So there has to be some caution with chiropractic adjustments or some aspects of physiotherapy or some types of massage. As I alluded to earlier, RA is more common in women. In fact, it's between 2 to 3 times more common. So that's certainly a risk factor. Genetics, it's estimated that 50% of RA risk is related to genetics, and it's associated especially with inherited antigen HLA-DR4, and also the genes PTP-N22, which happens in all sorts of races and cultures, and also the PADI4, which is only in the Asian population. Smoking is another risk factor, and likely the most significant non-genetic factor. Heavy smokers, particularly men, are 2.5 times more likely to develop RA. Age, of course, which is typically a risk factor in all kinds of arthritis. And most cases of RA is seen in adults between the ages of 35 to 55. Infections, some infections, particularly Epstein-Barr virus and the human herpes virus 6, are associated with RA. And there are a host of environmental factors that are often mentioned within these risk factors, but they're largely unknown and not commented on, not specified by mainstream medicine. Not surprisingly, outside the mainstream medical community, there are a variety of theories trying to explain why RA exists and or progresses. And one of the main ones centers around infections, particularly bacterial infections. So the so-called autoantibodies, labeled by mainstream medicine, are merely antibodies generated in response to pathogenic bacteria that have been killed by an immune system. So in essence, the body is reacting to collateral damage. Over time, dental infections have been implicated, in particular cavitations, which are cavities or pockets within the jawbone which house bacteria. Certainly root canals have been implicated as a main source of this because of the dead tissue that exists that the bacteria thrives upon. So the idea is the body is continually getting attacked, kind of a chronic low level of infections from these bacteria that live within these protected areas, not really in the mouth so much, but more in the jaw and deeper within the bone. Also, in a similar vein, we have unacknowledged or misunderstood pathogens, and these can include mycoplasma, possibly other viruses that are not yet discovered or not well understood, various fungi, possibly fragments of things that are not understood that can cause infections. We also have leaky gut syndrome. This is a theory that I personally like because it explains a lot of what we see in not only RA, but the so-called autoimmune diseases in general. And that is there's intestinal damage from allergic reactions to various foods, in particular gluten or other toxins that are widespread within our food chain. And this leads to inflammation and increased porosity within the small intestine and various undigested proteins, but also pathogens and certain toxins can enter the bloodstream, and this gets deposited in various joints and tissues within joints, in particular the synovium, and this could be what is causing the immune response to those tissues and joints. Another theory is just weakened immunity overall. So, in other words, the immune system is not overactive or faulty, but simply overworked or overwhelmed and suppressed from stress, poor diet, lots of sugar, for example, over medication, and the immune system is just not functioning properly to these pathogens or other conditions. Another one is vitamin D deficiency, because it's actually quite common in those with RA and may be causally associated. And lack of vitamin D is certainly related to reduced immune response and hormone imbalance, because essentially, even though it's called vitamin D, really it's been mislabeled as it truly acts more as a hormone than it does as the traditional role of a vitamin. Well, like with any other disease or really any type of arthritis, you're going to have a medical history and physical exam, and that's to establish genetic links and certain risks, and also to physically check out the joints for inflammation and typical signs such as deformity and RA nodes. Blood tests, of course, are quite definitive. You're looking for elevated erythrocyte sedimentation rate, or ESR. This is very common with RA, but it's a general sort of a thing because it just proves that there is quite a bit of inflammation in the body. Other studies are looking more specifically for rheumatoid factors, which are non-specific antibodies. But keep in mind that a negative RF does not rule out RA, as between 15 to 20% of cases are actually seronegative. RF is usually negative early in the disease, plus it's also found in about 10% of the healthy population and with other conditions, particularly hepatitis C, inflammation in general, Sjogren's syndrome. Other tests look for the presence of these anti-citrullinated protein antibodies that I spoke of earlier, or ACPAs, and it's positive in about 60%, 67% of RA cases, but it's rarely positive if not present, so it's said to have a high specificity. Imaging, of course, can be done. X-rays can show the loss of joint space over time, as it can in OA, and you can get an idea of some soft tissue swelling as well. Ultrasound is a bit better. It can depict early cartilage erosion, and it can visualize synovium swelling and certain vascular changes. Well, not surprisingly, there's a variety of ways of classifying RA, and this has changed over time. The American College of Rheumatology developed a system for classifying based mainly upon X-ray appearance. Of course, stage 1 is the least obvious, no damage, but the symptoms are present. And we go through stage 2, where there is some slight erosion in the cartilage, limited mobility. Stage 3, more of the same, just worse and more progressive. We also see the soft tissue nodes there with stage 3. And then stage 4 is the most destructive. We've got deformity, we've got the ankylosis, and usually extensive muscle atrophy and muscle pain with soft tissue nodes. There's newer criteria that were established in 2010, a little more complex, based on a point system from 0 to 10. And if you score 6 or higher, it's unequivocal RA. And this point system is based on many factors, such as how many joints are involved, which joints are involved, the RA factors, positive sedimentation rate, CRP values, and also the duration of symptoms. Here we have an X-ray. On the left we have a normal hand, and on the right we have one that's been affected by RA. As I mentioned, RA is of limited value in terms of diagnostics early on, but it certainly does visualize the changes, and it documents how the disease can progress over time. Here you can see around the knuckles, you can see areas that are a little more white or sclerotic. That's indicative of the inflammation process, and also the bone that's under stress and being broken down and destroyed. So we have inflammation, the cartilage erosion, we have reduced joint space. We also have something called ulnar deviation, where the deformity, the fingers are deviating towards, you could say, the outside or the ulnar part of the wrist. We also have the boutonniere deformity of the thumb, sometimes also called hitchhiker's thumb, where the end of the thumb almost looks like it's hyperextended. We have swan neck deformities in the other fingers, which almost kind of look like scoops, you could say. And of course, over time, the function of the hand and the wrist is severely limited. About 41 per 100,000 Americans are diagnosed every year with RA. The incidence increases with age, for example, about 9 per 100,000 for younger adults, and this is compared with about 54 per 100,000 for the older adults, 85 years older and older, which is an increase of a little over 6 times more. Although the incidence peaks between 65 and 74 years of age, keep in mind that most sufferers are women between the ages of 35 to 55. Interestingly, between the years 95 to 2007, rates increased by 2.5% yearly among women, but they actually decreased to 0.5% among men. Why is this? Environmental factors, dietary factors perhaps, hard to say. Overall lifetime risk in the U.S. is 4 to 5% for women and between 2 to 3% for men. In the U.S., Native Americans seem to have the highest risk, prevalence rate of 6%, and internationally, RA is most prevalent in Russia, Eastern Europe, and parts of South America, whereas it is lowest in parts of Asia, in particular Southeast Asia and Africa. North America, United States is kind of middle of the pack or slightly above. As I noted earlier, patients with RA have worse functional status, especially compared to those with OA or most other forms of arthritis, because RA is most prevalent in the hands and feet. So obviously it affects walking, mobility, picking up things, and doing various chores such as ironing, making food, things of that nature. RA patients are 40% more likely to report poor health and 30% more likely to need help with personal care, and even twice as likely to experience activity limitation compared to people without RA. RA patients report far more losses in function than people without arthritis, obviously, and it affects all activities, including work, leisure, social relations, sexual activity, you name it. Interestingly, and perhaps most scary, RA reduces the lifespan of patients by anywhere from 3 to 12 years. And in fact, RA accounts for about 22% of all deaths due to arthritis. And this is typically due to pericarditis or pleuritis or vasculitis, which triggers heart attacks, various breathing issues, and can trigger deadly infections. There are a variety of natural approaches that are appropriate for RA, but I'll stop short of calling them cures. These are simply natural things that can help with symptoms. Lifestyle changes, for example. Gentle exercise such as swimming, yoga, and Tai Chi may help reduce symptoms, but keep in mind that weight-bearing exercises often triggers flares, so jogging would not be a good thing. Weightlifting, it can be helpful for some people or it can trigger flares in others. In general, regular exercise improves muscle strength, can reduce joint stiffness, and can lower the risk of osteoporosis and disability, which is a good thing. Meditation, biofeedback are helpful too. There are a variety of physical treatments. Acupuncture for pain control, I'll talk a little bit more about that. Physiotherapy, chiropractic, massage. You've got to be a bit careful if OA is affecting the spine, particularly the upper neck. Cryotherapy, hydrotherapy can help with RA symptoms. But again, these modalities are typically more effective for OA than they are for RA, but it depends on the patient. There are many devices that a patient can use to help with symptoms. Wrist and hand splints, for example. Custom-made foot orthotics or orthopedic shoes can alleviate pain. Magnets can be helpful, whether they're implanted within these splints or braces or even within a mattress cover, for example, can certainly help with all sorts of arthritic pain. Keeping in mind the orientation of those magnets are important. They've got to be a certain side up. I can't remember if it's the plus or negative side, so I won't comment, but orientation of magnets is important for joint pain and inflammation. Acupuncture, of course, for pain and inflammation. A variety of herbal remedies, because some herbs are very good anti-inflammatories, and many other natural compounds. I'll touch upon omega-3 fats, GLA, vitamin D, vitamin C, selenium, MSM, etc. Thunder God vine is typically used for RA, for those that are into the herbal remedies. The root portion is used primarily, and this has been going on for hundreds of years in traditional Chinese medicine, so it's not something new. Thunder God vine is a good anti-inflammatory and seems to suppress immune response. In some studies in people and in animal studies, there's been a reduced rate of symptoms and degree of symptoms with RA, taken orally or applied topically. The downside is it does have a fairly high rate of side effects, relatively speaking, in terms of herbal remedies, but of course not out of order or out of whack compared to pharmaceuticals. Oral doses range from 180 to 570 milligrams daily. And this has been tested for up to 20 weeks at a time for RA symptoms. But again, you got to keep an eye on some side effects, whether they be GI effects or sometimes increased risk of infections because of the immune suppression. Boswellia resin, these plants, also known as frankincense, they've shown good anti-inflammatory and immune system effects. The most active compound is called AKBA or AKBA. The extract doses range from 250 to 1,000 milligrams daily, and usually results occur after about a week. And this is much safer to take long-term compared to the Thunder God vine. Turmeric root, which of course contains curcumin, which is found in a variety of curry powders, is a strong anti-inflammatory and analgesic, so it's appropriate for all types of arthritis, other inflammatory conditions, and it performs as well as ibuprofen and diclofenac in various studies, but of course without the side effects. Doses range from about 300 to 600 milligrams 3 times daily for RA, but it's also a blood thinner, so you have to be careful with the various blood thinning medications that you may be on. Devil's Claw is another anti-inflammatory and analgesic. Studies indicate that taking this for 8 to 12 weeks does reduce joint pain and improves function, especially of the spine, hips, and knees. It's a little more common for OA, but for RA you just have to bump the doses a little bit, and these range from between 100 to 200 milligrams twice daily. It's also a blood thinner and vasodilator, so caution needs to be exercised when taking it with other medications. Other decent herbs for RA and other types of arthritis include ginger root, willow bark, and capsaicin. Ginger root acts like a COX-2 inhibitor, much like Celebrex or the old Vioxx did. You're looking at least 2,000 milligrams daily in divided doses to be helpful for RA. Also has blood-thinning properties. Willow bark contains salicin, and of course this was used in the late 1800s to make acetyl salicylic acid, otherwise known as aspirin. It works a little slower for pain relief than ASA, but it's safer and lasts longer. You're looking at 300 to 500 milligrams 3 times daily for RA, and of course it's a blood thinner. Capsaicin, which is derived from the cayenne peppers, often applied as a cream directly over the inflamed joints. The short-term reduction in substance P is the main way that it works, and it's a chemical that contributes to joint pain. It also distracts the brain from focusing on the pain signals because the capsaicin can cause a lot of tingling, kind of topical irritation. Typically at least 3 days of application are needed for results with RA. However, it doesn't improve joint swelling or improve joint function. Omega-3 fats include ALA, EPA, and DHA. They exhibit strong anti-inflammatory properties and they aid in tissue repair. EPA, DHA found in fatty fish oils, where ALA is primarily in flaxseed, hemp, and walnuts. I would think about 1,000 milligrams 2 to 4 times daily is necessary for noticeable anti-inflammatory effects. Of course, the American diet is low in omega-3s and relatively high in omega-6s. You're looking for a ratio ideally to be 1 to 1 or 2 to 1 in favor of omega-6, where typically the American diet can have a ratio of 20 to 1 or even 30 to 1 in favor of omega-6s. Borage seed oil. This is essentially the richest source of gamma-linolenic acid, or GLA, although other sources do include black currant seed and evening primrose oils. GLA inhibits leukotrienes and demonstrates anti-inflammatory benefits. In terms of dosage, 1 to 3 grams daily for at least 24 weeks for noticeable effects. And it may lower the threshold for seizures, so epileptics need to show some caution with this supplement. Vitamin D, as I mentioned earlier, can be quite important. The official RDA is between 600 to 800 IUs per day, which is far too low in my opinion. For example, a Caucasian person during the summertime, out in the sun midday in a bathing suit, produces tens of thousands of IUs in under an hour. So the body can handle quite a bit of this. Now that's D3, which is the safest form for supplement. You know, up to 40,000 IU daily has been proven to be safe. And of course your body makes it from sun exposure. Another vitamin where the RDA is far too low is vitamin C. Megadoses of between 1,000 and even 2,000 milligrams 3 to 5 times daily can be very beneficial for a lot of things, including infections and fighting inflammation. Plus, vitamin C is also needed for collagen repair. And the interesting thing is, essentially all primates are unique in the animal kingdom in that they don't produce vitamin C. Your dog, your cat does, you do not. The 70 to 120 milligrams daily for the RTA is ridiculously low. We need much more than that on a daily basis, particularly if you're dealing with infections and inflammation. You have to up it, you have to megadose, quote unquote. MSM, or methylsulfonyl-methane, it's a good source of sulfur, and it's needed by the body to produce chondroitin sulfate. This is particularly important for OA, less so for RA, although MSM is also a good anti-inflammatory. Selenium, RDA is 55 micrograms, and that seems to be about right, although many people don't get that amount. More than 200 micrograms daily may cause some issues, so certainly stay under that if you're supplementing. And this is a strong antioxidant and needed for normal immune function. Works in tandem with zinc in immunity and stimulates white blood cell production. And much like vitamin D, people with RA are also low in selenium. As I mentioned earlier, if leaky gut syndrome is associated with autoimmune conditions such as RA, then dietary changes are important. Dr. Fasano from the University of Maryland Medical School believes that three main factors underpin most, if not all, autoimmune diseases, including RA. Number one, a foreign substance is recognized by the body. Two, the immune system overacts to the substance. And three, the intestines are usually too permeable and they allow in these foreign substances, pathogens, toxins, etc. With leaky gut syndrome, there's large spaces between the cells in the duodenal wall, which is the initial portion of the small intestine. And as I mentioned, it allows entry to a variety of things that the immune system views as foreign and potentially harmful, and obviously it reacts to it. Gluten, which is a plant protein, or really gluten is a term for a collection of different plant proteins. It's found particularly in grains such as wheat, barley, and rye, and it is likely the most common trigger for leaky gut syndrome, although there are other toxins found in beans and root vegetables, for example, that are also factors. And of course, there's a whole host of other things that can injure the small intestine and cause inflammation, such as medications, alcohol, etc. But in terms of the quote-unquote natural things in food, we have to look out for the gluten and natural toxins in beans and root vegetables. The main purpose of drug therapy for RA is to minimize the pain and swelling and to prevent possible bone destruction and deformity, and obviously to minimize disability. There are dozens of meds used to treat RA, and the main groups are over-the-counter NSAIDs, prescription NSAIDs such as COX-2 inhibitors, steroidal anti-inflammatories, DMARDS, and there's also older classes of immune suppressants that are still used. Keep in mind, medications are not curative, and some, especially some of the NSAIDs, can actually accelerate the joint destruction with long-term use, which is ironic, seeing as how you're treating an arthritic condition. The primary over-the-counter non-steroidal anti-inflammatories are ibuprofen, of course, brand names Advil, Motrin, naproxen, brand names Aleve, naproxen, and of course ASA, aspirin or anisin. NSAIDs help relieve pain and inflammation of RA, of course, but they have a high incidence of side effects, particularly involving the GI system, like ulcers and various degrees of irritation. In terms of risk of serious stomach problems, ASA would be the worst, followed by naproxen, and then followed by ibuprofen after that. Most NSAIDs do increase the risk of heart attack also, but not naproxen. ASA is a non-selective COX inhibitor, but it does select out more COX-1. Ibuprofen and naproxen are also non-selective, but they shade out a little more COX-2. In terms of dosages, ASA 1,000 milligrams 3 times daily is the max. Ibuprofen a little less, 400 to 800 every 6 hours to 3,200 max. Naproxen even less. The max per day there is about 1,650 milligrams. But again, it depends on the person, depends on size, your weight, etc. If you're a very small person, then clearly the max dosage would be less for you, based on symptoms. Some studies show that long-term use of NSAIDs actually accelerate cartilage erosion, like I alluded to. So they're often not good options for any arthritic condition long-term. There's also creams available that are based on the NSAIDs, Theragen, for example, and Bengay, that you can get over the counter. Prescription NSAIDs for RA. There's a variety of prescription NSAIDs that have a little more bite to them, I guess you could say, than the over-the-counter varieties. For example, COX-2 inhibitors such as Celebrex can be quite effective for pain control and inflammation, and they're also much easier on the stomach. However, they have a much higher risk of myocardial infarction and stroke, which is why the FDA removed a few of them, particularly Vioxx in 2004 and Bextra in 2005. They're also much more expensive compared to other prescription NSAIDs, such as diclofenac, diflucinal, and indomethacin. Celebrex doses for RA are between 100 and 200 milligrams twice daily. Other prescription NSAIDs include diclofenac, brand names Voltaren, Cataflam, and these are acetic acid derivatives. Dosages between 150 and 200 milligrams daily, typically in 2 to 4 divided doses. Diflucinal, brand name Dolobid, is a carboxylic acid derivative. Dosages are a little higher, between 500 to 1,000, divided into typically 2 different doses. Ketoprofen was available over the counter in the US, but now it is by prescription only. Dosages are about 200 milligrams, at least the extended release capsules. Ketoprofen-based power gel, 2.5% strength, is also available by prescription, and that's for topical application to go right on the inflamed joints. Steroidal anti-inflammatories, known as corticosteroids, and these include cortisone, prednisone, prednisolone, and these are strong anti-inflammatories and that mimic the body's adrenal hormones. They suppress immunity, which is certainly helpful for the so-called autoimmune conditions like RA, but in reality not good for health in general, so long-term use is problematic. Obviously, we need a healthy and functioning immune system for health. Cortisone injections are more common for OA, but because RA is typically much more systemic, pills, creams, and even intranasal sprays are much more common. If you are injecting joints, there certainly is a limit, typically between 2 to 4 injections per joint per year, but it depends on the size of the joint, effectiveness, dosage, and the side effects experienced. For RA, low-dose corticosteroids, typically 7.5 milligrams daily, are used as a so-called bridge therapy until the slower-acting DMARDS become effective. Larger doses, and I'm talking typically about 25 milligrams daily, are used short-term to treat the RA flares because they are powerful anti-inflammatories. Lots of side effects with corticosteroids, though. Edema, weight gain, increased blood pressure, and even eye pressure called glaucoma, mood swings, fatigue, depression, increased risk of infections because of the suppressed immunity, and various skin issues and bone problems, including osteoporosis. DMARDs, standing for disease-modifying anti-rheumatic drugs, are the mainstay to treat RA, and they work slowly to modify the course of RA. They promote remission and prevent progressive joint destruction. So odds are, if you have a diagnosis of RA, you're definitely on DMARDs and usually a couple of other class types of drugs. There are about a dozen of DMARDs to choose from. I would say the most common is methotrexate, brand names Rheumatoid, Trexol, Folex. Adults with RA usually start by taking between 7.5 and 10 milligrams, and this typically means 3 to 4 pills, all at once per week. This dose may be increased up to 25 milligrams a week over time if needed, but it takes a while to be effective, typically 3 weeks, but more often closer to 12 weeks in some patients. So again, slow acting. Methotrexate is available as a liquid or injection aside from pills. However, this drug does increase liver enzymes in about 15% of patients, and it's teratogenic, so it should not be given to women that are pregnant or thinking or wanting to get pregnant. As mentioned, DMARDs are not used in isolation typically, but they're used in conjunction with NSAIDs or steroidal drugs. And typically, after 12 weeks, if symptoms are not dramatically better, then other so-called biological agents are considered. Biologics, also called biologic response modifiers, are actually a type of DMARD, and in fact the newest category of meds to treat RA. And these biologics all must be injected. They block specific steps in the inflammatory process, so they're better in the sense they don't wipe out the entire immune response as other immune suppressants for RA commonly do. A type of biologic is TNF-alpha inhibitors, and specifically these block the cytokine called tumor necrosis factor, particularly the alpha type, which is an inflammatory substance. And the TNF alpha inhibitors include Cimzia, Enbrel, Humira, Remicade, and Simponi. Kineret blocks a cytokine called interleukin-1. Actemra blocks interleukin-6. Orencia blocks the activation of T cells. And Rituxan blocks B cell activation. So they all target different steps in the inflammatory cascade and suppress the immune system in, I guess you could say, partial degrees, not globally. These biologics have shown great effectiveness in controlling inflammation and preventing joint erosion and deformity, but they are expensive and they induce many side effects, including severe nausea, diarrhea, hair loss, and greater risk of serious infections, in particular tuberculosis. Another newer subset of the DMARDS are called JAK inhibitors because they block the so-called Janus kinase pathways that are involved in the body's immune response, and these are supposedly out of whack in people with RA. Unlike the biologics I had just outlined, JAK inhibitors can be taken orally. The newest one, as of 2012, is called tofacitinib and is being compared favorably to the biologics in terms of symptom control for RA. Another one, currently known as SB 1578, inhibits the JAK2 pathways and is fairly effective, at least in animal studies. SYK or SYK inhibitors are similar, but they block the spleen tyrosine kinase pathway. A particular one called fostamatinib works well with methotrexate for reducing RA symptoms. Older immune suppressants tame or block immunity in a global fashion, and they can be viewed as really the original types of DMARDs. And they used to be the top choice for RA, primarily because the medical model assumed the immune system was completely out of control and needed complete suppression for control of the symptoms. However, not surprisingly, these global immune suppressants greatly increased the risk of serious infections because, of course, they essentially destroy the immune system response and they greatly impair healing. And examples of these older immune suppressants: azathioprine, cyclosporin. Keep in mind that corticosteroids globally suppress the immunity also. In general, these global immune suppressants are rarely prescribed for RA, particularly long-term, because other newer DMARDs, they work much better and they have fewer side effects, although they are much more expensive. An active area of research for RA focuses on antibodies, and these are proteins made by the immune system that identify disease-causing agents. Several antibodies are already approved by the FDA for use with RA, and new ones are being studied currently for their effectiveness. For example, a drug known as Prolia targets a molecule called rankle, and that's a cytokine that plays an inflammatory role. There's a variety of others. For example, Arzera. It's already approved for treating leukemia, by the way, but it's an anti-CD20 monoclonal antibody that's currently being studied for RA because it does reduce aspects of the inflammation cascade. Other monoclonal antibodies include Simulect, Zenapax, and Orthoclone. And these treatments are typically given as injections or infusions, much like other biologics are. The Prosorba column. This column is a type of really filtration treatment, and it involves pumping blood drawn from a vein into an apheresis machine, a cell separator, and it separates the plasma from the blood cells. This column is a plastic cylinder, approximately the size of a large coffee mug, for example, and it contains a sand-like substance that's coated with a material called protein A. And this substance binds to unwanted antibodies from the plasma, particularly ones that promote RA, and this sand-like substance removes them from the plasma. The prosorba column is indicated for moderate to severe RA that hasn't responded very well to the DMARDS, or for patients that are allergic to such medications. If the disability and symptoms are great with RA and conservative management, either through natural supplementation and herbs or pharmaceuticals, is ineffective, then there are various surgeries to consider, particularly for weight-bearing joints because, of course, they're important for mobility. If RA is in its early stages, then a synovectomy can be performed. This consists of removing the inflamed tissue, synovial tissue, from the synovial joint. This can help prevent destruction from RA, but long-term it does promote osteoarthritis because there is far less lubrication within the joint, which promotes wear and tear. There's also regular arthroscopic surgery, trimming the damaged cartilage, etc. This is not especially effective for symptoms of RA. It's usually much more effective for OA. With severe RA, complete joint replacement surgery or arthroplasty may be considered, and this does often reduce the pain and increases function. These synthetic joints are made of a variety of metals and plastics. Osteotomy can be considered, which is essentially a realignment of joints. It can be done in the hands, particularly, let's say, the big toe or thumb, which can increase function, but it also depends on the degree of destruction that is there. Arthrodesis is a surgical fusion of joints. This can be done in the toes and the fingers, but usually more often in the spine in order to promote joint stability. Because RA does affect tendons and ligaments, those sorts of surgical repairs are common, in particular for helping with trigger finger or swan neck deformities. And of course, surgery does carry quite a bit of risk in terms of excessive bleeding, infection. Of course, it can create pain in itself.